for kindly inviting me to this event. I also want to thank my research director, Professor Marie-Josée Drolet, for her contribution and insightful comments on this presentation. So today I will share with you my preliminary draft of the first article of my doctoral thesis. So I'm very interested in hearing your comments and feedback at the end of the talk. So in this first article, I review the concepts used in the academic and activist literature to describe the injustices in mental health care, and argue that the concept of sainism is best suited to understand the structural mechanisms and social determinants that perpetuate these injustices. So before we start, I would like to ask you to write in the chat 3 words or concepts that spontaneously comes to your mind when you think of injustices related to mental health care. So feel free to share to everyone these 3 words or concepts in the chat. I'll give you maybe 1 minute. Thanks for your participation. There are really interesting words in the chat if everyone wants to look at them. I invite you to keep those words in mind throughout the presentation, as we will return to them at the end. Okay, so my presentation will follow this outline. First, I will position myself and my research in the critical framework of MAD studies. Next, I will present 4 main concepts used in the reviewed literature to describe the injustices related to mental health care. Then I will submit 4 arguments in favor of using sainism as a key concept to understand these injustices. And finally, I will conclude by explaining the next steps of my doctoral research. So as a Western white woman who has interacted with the mental health system to a large extent as a healthcare professional, I recognize my privileged position in relation to my topic of research. I am aware that I may have a bias derived from dominant medical knowledge because of my training and work experience as an occupational therapist in community mental health. To limit their influence on my research, I have chosen to critically engage with the field of MAD studies, which is explicitly informed by the lived experiences of MAD people and scholars. So as you may know, MAD studies is an interdisciplinary field of critical scholarship and political action dedicated to criticizing and overcoming the dominant psychiatric model. So building on the collective knowledge of the MAD community with a great humility and also a great respect, I aim to dig deeper than the medical and individualistic model of mental health to better understand the injustices that these people experience. So this pretty illustration by artist and activist Alice Ruriani explains well the global and intersectional approach I adopt in my research. So to describe the injustices experienced by MAD people in mental health care, 4 main concepts are used in the literature. These are stigma, occupational injustices, epistemic injustices, and sainism. So in the next slides, I will define each concept, map their uses in the literature, and summarize the main findings stemming from them in the literature. So originating from the work of sociologist Irving Goffman, stigma is defined as the attribution of a label of shame and disapproval to individuals with a social identity that is deemed outside of the norm. In the case of mad people, they are stigmatized because their health status is socially perceived as deviant or even undesirable. So the concept of stigma is the most frequently used in the reviewed literature. Twice as many mental health publications use the concept of stigma compared to discrimination to talk about these issues. So these studies focus largely on stigmatizing attitudes of mental health professionals and the consequences experienced individually by mad people. A mental health system is perceived to be one of the most stigmatizing environments. In fact, as up to 44% of service users report experiencing stigma in mental health care, resulting in a lack of respect and paternalistic behaviors from healthcare professionals. Therefore, it negatively affects the quality of care, causes discriminatory practices, and delays requests for mental health support. Strategies proposed in the literature to reduce stigma emphasize contact hypothesis, which suggests that increasing positive and egalitarian intergroup contact can lower stigmatizing attitudes. So the next concept is occupational injustices. So mentioned for the first time in the work of occupational therapist and philosopher Anne Wilcock, occupational injustices occur when a person or a social group do not have the same opportunities as the rest of the population to engage in occupations because of institutional and societal barriers. So just to be clear, occupations are daily activities that give meaning to life and contributes to one's health. So the reviewed literature about occupational injustices in mental health care comes exclusively from the disciplines of occupational therapy and occupational science. It highlights that people have limited occupational possibilities in inpatient mental health facilities because of institutional constraints, which can lead to occupational deprivation. So these constraints include the isolation from the rest of the community, inflexible policies and procedures, strict living routines, and paternalistic practices by caregivers. The literature also suggests that mad people lack control over the organization of mental health services and that therapeutic activities are often imposed to them, which contributes to another form of occupational injustice. Strategies proposed to overcome them emphasize the patient's involvement in their care to increase meaningful occupational opportunities. So the next concept is epistemic injustices. So popularized by the work of philosopher Miranda Fricker, epistemic injustices are defined as the harm made to someone specifically in their capacity as a knower. So as you may know, Fricker describes two types of epistemic injustices that are mutually reinforcing in their effects. First, testimonial injustices that occurs when an undue deficit of credibility is given to a person's testimony because of identity prejudice. And second, hermeneutical injustice that occurs when a gap in collective interpretive resources does not allow a marginalized group to make sense of their own experiences. So the reviewed literature suggests that Mad people are particularly vulnerable to epistemic injustices. Many concepts related to the two main types of epistemic injustices are discussed, mainly from a theoretical perspective, but also from lived experiences to a lesser extent. Most of the articles stress the impact of testimonial injustices on therapeutic relationship, especially how Mad people's experiential knowledge are invalidated by healthcare professionals in position of power. A minority of these writings also recognize the testimonial injustice they face at an institutional level and the larger marginalization of their knowledge at the level of the society, causing hermeneutical injustices. To foster epistemic justice in mental health care, the reviewed literature mainly emphasizes strategies that focus on developing epistemic humility in healthcare professionals. So the concept of interest, sainism, emerging from the Mad movement and popularized by lawyer Michael Perlin, sainism is defined as the systemic oppression of those categorized as having a mental health disorder or as not being quote unquote sane. So this form of oppression is based on stereotypes rooted in the biomedical model of mental health. So this biomedical model sustains negative identity prejudices against Mad people perceived as dangerous or irrational, for example. These prejudices support the belief that Mad people are fundamentally different from others. This, in turn, normalizes their discrimination within social institutions and maintains systemic power dynamics that disadvantage them. Sainism is thus understood as an overarching oppression leading to stigma, occupational injustices, and epistemic injustices, and other forms of injustices in mental health. So while sainism is the preferred concept in activist and Mad studies literature to account for injustices in mental health care, it is rarely used in academic literature. Few critical reflections emerging mainly from the work of Mad healthcare professionals and scholars show that the training and practices of allied health professions, such as social work or occupational therapy, for example, remain centered on dominant psychiatric discourses and mostly focused on reducing behaviors deemed inappropriate or disrupting, rather than focusing on the need of the Mad people themselves. Research on sainism in mental health care also found that healthcare professionals predominantly view recovery as an individual responsibility, depending on will and efforts, for example, instead of a social process. So to address sainism in mental health care, the reviewed literature emphasizes the need to develop anti-oppressive and transformative clinical practices sensitive to the social determinant of health. So in short, the literature review shows that stigma is the most frequently used concept to understand injustices in mental health care. It also points that the concept of occupational and epistemic injustices are used to describe specific types of harm done to Mad people in the mental health care settings. But above all, It reveals that while sainism is conceptualized as the overarching operation producing stigma and other forms of mental health injustices, it remains rarely used in the literature outside of MAD studies. So in what follows, I will submit 4 arguments toward the use of sainism as a key concept to understand injustices related to mental health in the academic literature. So firstly, sainism is a concept closely linked to the experiences of MAD people themselves, as it has emerged from the MAD movement. Also referred as mentalism or as sane chauvinism by groups of people identifying as consumers, survivors, and ex-patients, sainism is an interpretive resource generated by MAD people to understand their experiences of injustice. I think that the lesser interest in this concept can be explained in part by the contributory injustice faced by the MAD community, which is produced when the dominant group dismiss the resources that marginalized group develop to make sense of their own social experience. So thus, from an ethical point of view, it is important to recognize the value of interpretive resources developed by the MAD community and to engage with these concepts in our writings without appropriating them, of course. My second argument is that the concept of sainism allows us to understand the oppressive power relationships at stake in mental health system. So unlike stigma that focuses on individual negative attitudes, sainism highlights the oppression rooted in and reinforced by psychiatry that causes prejudice and discrimination against MAD people. Indeed, the concept of sainism actively challenges the dominant biomedical model of mental illness that structures mental health care and policies, and more largely favors people deemed sane over those perceived as mad in the society. So in shedding light on the structural causes of mental health injustices, the concept of sainism helps us recognize that effective strategies to counter such injustices must be in line with alternative approaches to psychiatry that address mental health from a social perspective. Thirdly, the concept of sainism allows for an intersectional analysis of mental health injustices. So, in other words, it clearly acknowledges that mental health injustices as differentiated manifestations and effects depending on the multiple social identities of MAD people. So it is true that some writings use the concept of intersectional stigma to take into account the fact that mental health stigma can be exacerbated by other aspects of one identity and its experience, such as race, gender, housing status, or substance use, for example. However, I think that it is insufficient to understand how the multiple oppressions experienced by MAD people overlaps and are mutually reinforcing each other. In fact, I think that conceptualizing sainism as an oppression that intersects with other forms of oppression, for example, racism, to create a specific form of outcome, in this case, anti-Black sainism, is far more appropriate in my opinion. So my last argument is that the concept of sainism supports the implementation of strategies based on radical co-production of knowledge to overcome epistemic injustices in mental health care. Specifically, I think it is necessary to recognize the close relationship between sainism and epistemic injustices in mental health to implement strategies in mental health care and research that go beyond biomedicalized participatory practices. So in coherence with the finding of this literature review, Rousseau states that, and I quote, testimonial injustice is mainly seen as intrinsic to quote-unquote mental illness and is commonly approached in terms of quality of the contact with quote-unquote patients, end of the quote. In addition, hermeneutical injustices are less discussed in the academic literature, illustrating that the dominant biomedical model of mental illness is largely left unquestioned. Therefore, understanding how epistemic injustices are linked with Sanism makes it clear that it is not enough to listen to mad people and to include them in mainstream clinical practices, but that we must also collaborate and support their efforts to transform the clinical practices and the system. So in conclusion, Sainism is conceptualized as the overarching oppression of those categorized as having a mental health disorder or as not being quote-unquote sane. So finding from this review shows that while Sainism is the preferred concept in activist and math studies literature, it is used to a lesser extent in academic writings. Despite this, I have argued that this concept is best suited to understand the structural mechanism and social determinants of injustices related to mental health care, namely because it constitutes an interpretive resource developed by the math community. It highlights oppressive power relationships at stake. It allows an intersectional analysis, and it supports the implementation of strategies based on radical co-production of knowledge. So in the next steps of my doctoral research, I will conduct a critical concept analysis of Sainism to provide a clear and operational definition of this concept and to clarify its relationships with other concepts used in the mental health literature. I will then empirically validate my analysis by giving the voice to the mad people directly affected by this systemic oppression in Quebec's mental health system. Finally, I will make a synthesis of solutions highlighted both by those interviewed people and in the literature to fight sainism. So as an opening question to the end of my talk, I would like to ask you if you think that other words written in the chat or concepts should be considered as key concepts to understand injustices related to mental health care, and if they relate to sainism in your opinion. So I'm very interested also to hear your thoughts and comments on my presentation, since this paper is in the progress. And thank you so much again for being here today. So these are my reference and my contact if you want to write to me.